Well, we'd like to thank the organizers for inviting us here today to present the guest lecture, There's More to Life Than Death. As you've heard, we're both physicians and teachers at Harvard Medical School in Boston. And in these roles, we spend a lot of time working to stay up to date on the latest medical advances. And one thing that we have found striking is that despite all the recent medical advances, all the application of scientific principles to medicine, and all the sophisticated data analysis that we have available now, there seems to be increasing controversy among experts about how to prevent or treat even the most common conditions. And this kind of uncertainty is very unnerving to both physicians and patients. Now, uncertainty and controversy in medicine is not new. But what is new is how medical controversy is endlessly featured in the lay press. Everyone is now directly confronted with medical information and advice through the media. You can't pick up a newspaper or a magazine, turn on the television or the radio, and certainly you can't surf the internet without encountering medical information and advice. In fact, we ourselves often read about the latest medical controversies in the lay press even before we see them in the medical literature. So we'd like to use the next few slides to show you some examples of this. Okay, so the debate about PSA testing and treatment of prostate cancer is one that's very familiar to all of you. And this controversy has been absolutely everywhere in the United States. Should a healthy man have PSA testing, and does this kind of testing save lives? So this debate was highlighted in a television special on public broadcasting in the United States, and almost exactly a year later, the same controversy was featured in the Wall Street Journal as a counterpoint. At what age and how often should a woman have a mammogram? Do mammograms save lives? Now, this kind of controversy is not limited to cancer screening. Should everyone with an elevated cholesterol be treated with a statin? Recently, new guidelines came out in the United States to address this question, and almost immediately there was intense debate, with many experts arguing that too many people would be treated without benefit. There were also controversial new guidelines about the treatment of high blood pressure. What blood pressure needs to be treated? And a recent study in the New England Journal of Medicine and several others that followed raised doubts about one of the most basic and accepted approaches to the treatment of hypertension, the low-salt diet. Another controversy that's been in the news has been centering on vitamin D. Should everyone take vitamin D? And if so, how much? What's the normal level of vitamin D? And should you even be measuring vitamin D? So in November 2011, the Institute of Medicine released their report on vitamin D, hoping to settle this controversy. And these were the two conflicting headlines that came out on the very same day. The New York Times saying extra vitamin D is not necessary, and the Wall Street Journal, on the contrary, saying that you need to triple your intake of vitamin D. So every one of these issues, and many more, remain active controversies, both in medical journals and the lay press. So why are these experts disagreeing? Why isn't there a clear right answer? And how do physicians and patients make their decisions in the face of this kind of controversy? We didn't have a ready answer, so we began to search.
So we went back to the textbooks and looked at classic medical decision analysis, which is derived from economics. And a formula is used to calculate what is the best decision. And this formula is derived from Daniel Bernoulli, who was a mathematician in Holland in the 1700s. Now, Bernoulli was looking at decision-making in the marketplace. And he said that the best choice is calculated by looking at the probability of a certain outcome and multiplying it by the utility or the impact that that outcome has. Now, in economics, the probability of an outcome might mean the chance of selling a certain number of products. Utility is basically the profit in sterling or dollars or euros, the impact on the bottom line. And this formula underlies much of economic decision analysis. Now, this formula and this approach has been imported into our profession, medicine. And here you can estimate the probability of an outcome. For example, consider treatment of prostate cancer. You can look at the probability of an outcome of a certain side effect, for example, urinary incontinence. But then the question becomes, how do you put a number on the second part of the equation, on the utility, on the impact it has on your life? Now, there are three different methods that have been used in classic medical decision analysis. The first is a linear rating scale from 0 to 1. 0 is death, and 1 is, quote, perfect health. And you're supposed to look at the scale and say, well, if I developed urinary incontinence, my life would be at this point between 0 and 1. Another method is called the time trade-off. Here you're asked, how many years of life would you be willing to trade off or give up in order to avoid becoming incontinent? And the third is called the standard gamble, and this comes from game theory. Here you're asked to imagine there is a magic pill, and that magic pill can prevent a certain outcome, such as incontinence. But in a certain percentage of cases, it causes instant death. And you're supposed to estimate what odds you would be willing to take to completely avoid a certain outcome versus the chance that it might kill you right off the bat. Now, recent research in cognitive psychology has shown that these three methods are all severely flawed. The problem is you cannot reliably forecast your life in the future. You can't accurately understand the impact that a certain outcome will have if you've never experienced it. Also, as this audience well knows, medical conditions are not static. They're dynamic. And people also adapt to their condition. So the impact on your life is changing over time. Now, what happens when you ask people who actually have a medical problem or condition? For example, healthy people, when surveyed, say that being blind on a scale of 0 to 1 is 0.5. It reduces the utility of your life by 50%. Now, I happen to have a first cousin who has been blind since birth. She was born prematurely in the late 1940s and exposed to high levels of oxygen that destroyed her retina. My first cousin worked her entire life as a teacher. She speaks 4 languages. She's currently retired and volunteers in a senior living facility helping sight-impaired elderly people, teaching them how to use Braille and computers to access information. If you told my first cousin that her life was 0.5 on a scale of 0 to 1, she would slug you in the face. So when you speak to people who actually have a medical condition, their assessment of their own life is very, very different than what people who are healthy or have never experienced the medical condition believe. So this entire structure of medical decision-making is deeply flawed. In fact, Daniel Kahneman, the Nobel Prize winner in economics, who has pioneered cognitive psychology, recently gave an address to a medical decision-making meeting, and he said, this classic paradigm of measuring utility is like measuring the ether in 19th century physics when the ether did not exist.
So we realized the textbooks were not giving us the answers that we were looking for. And then we thought about Sir William Osler, one of the most famous physicians of all times, who practiced in the late 1800s and early 1900s. And he made the following comment about making a difficult diagnosis. He said, "Listen to the patient, because if you know how to listen, he's telling you the answer." So we decided to do some field research and to listen. We interviewed scores of patients and physicians in great depth, and we asked them how they made their medical decisions. And although we found that people were individual in how they made their decisions, there were common threads in the approaches that they took to their medical problems and generally maintaining their health. And to explain these common threads, we'd like to include all of you right now in a thought experiment. And we'll just begin by asking you a few questions. So raise your hand if you yourself have been a patient over the last year. And by patient, I mean not only have you been admitted to the hospital or to the emergency room, but have you just had a checkup or a visit to your doctor for a minor medical problem? So most people. Now try to remember the experience of being a patient. Try to put yourself in the mindset of being a patient. And now imagine that you're sitting in your doctor's office and your doctor tells you that your blood pressure is too high. And although you have been exercising, you've changed your diet, and lost weight, your blood pressure is still too high. So now your doctor tells you it's time for medicine. So raise your hand if you would want to be proactive. You want to aim for perfect blood pressure control, and you'll do whatever it takes to get that. Okay? Now raise your hand if you feel that your blood pressure doesn't need to be absolutely perfect, you just want the minimum of medication. Okay, so the first group, that's the maximalists. You want to be ahead of the curve, do everything and more. The second group, those are the minimalists. Less is more.
So your doctor prescribes the blood pressure medication, and it turns out the medication comes in two forms. One is extracted from an herb, a natural source. The other is synthesized in a laboratory using the latest technology. Both pills are chemically identical and cost the same. Your doctor offers you a choice. Raise your hand if you would prefer to have a medication extracted from a natural source. Okay? And raise your hand if you want a medication synthesized using the latest technology. So the first group is what is called individuals with a naturalism orientation. These are people who look to nature, to natural sources, and if they have problems that might be amenable to interventions such as acupuncture or massage or meditation, such as pain, as we just heard, they look to that source. The second group, we call them those with a technology orientation. These are individuals who generally look to science and the latest, greatest high-tech breakthrough, cutting-edge treatments.
So finally, your doctor gives you a prescription for the medication that you chose, and now you're sitting down and you're just ready to take your first dose. So raise your hand if you take the pill out of the bottle and swallow it down, confident that you're on the right path to solving your problem of high blood pressure. Now raise your hand if you take the pill out of the bottle, stare at it for a while, then read the package insert in great detail regarding all the possible side effects twice, and then wonder if you should really take it. So the first group we term the believers. Believers, are certain that there's a good solution for their problem, and once they find the solution, they're ready to just go for it. Doubters, that's the second group, worry that the treatment will be worse than the disease. So the terms for these mindsets came out of the many interviews that we did. These were the common threads that reflected the approaches of both patients and doctors to their health and to medical problems when they arose. And these mindsets applied not only to problems like high blood pressure or elevated cholesterol, but also to decisions around surgery and treatment of cancer. So we want to emphasize that it's not just patients who have these mindsets. Doctors, experts have these mindsets too. So now we want to get a little personal and talk about our own mindsets. And Jerry, you can go first.
Okay. I was raised in a family with a strong Eastern European Jewish tradition where doctors were on a pedestal. Physicians like Jonas Salk and Albert Sabin were heroes for their work with polio. Science and technology were greatly honored as well, and anything that was thought to be natural was a throwback to ignorant village life in Eastern Europe. So I was raised as a believer with a technology orientation. And being a believer meant doing everything to the maximum. The attitude was every medication, every pill must mean better health. My father, in his early 50s, had a massive heart attack and died. He may have died because he did not get intensive cutting-edge treatment. Possibly he could have survived if there had been a cardiologist available. Of course, he may have died even with intensive care unit treatment. But this experience reinforced my belief in intensive interventions. And the maximalist mindset extended not only to heart disease, but basically to all of medicine. And my choice in the 1970s to become a hematologist and oncologist and work in bone marrow transplantation fit with this maximalist point of view, providing the most intensive interventions for people with leukemia and lymphoma who otherwise may have died. So my medical mind is that of a maximalist and a believer.
And I had a different kind of upbringing. I was the first child in my family, and when I was a baby, the doctor informed my parents that the new scientific way to feed a baby was every 4 hours by the clock. And my dad, who was an engineer, was very enthusiastic about applying scientific principles to child rearing. So he made a very detailed chart for my mother so that she could check off every 4 hours when she fed me, and then he went off to work. And my mother had a pretty miserable first day at home with screaming baby, and it didn't take too long before she decided to take matters into her own hands, feed me when she thought I was hungry. When my dad came home, he was appalled. How can you not follow the instructions of the doctors, the experts? And her response was that of a doubter. Experts don't know everything. Now, my parents were ahead of their time with respect to a healthy lifestyle. They never smoked. They were avid exercisers. My dad used to get my sisters and I up early in the morning to do the Royal Canadian Air Force exercises with him. And my mom had us eating whole wheat bread, which in the 1950s was not a very tasty item for kids to have to eat. My parents have had the good fortune, by virtue of their lifestyle and or their genes, to live long and healthy lives with a minimum of medical intervention. They're now in their 90s, and they both still work out in the gym every day. And this background has contributed to my minimalist doubter point of view. So Jerry's a maximalist and a believer, and I'm a minimalist and a doubter. And we maintain these mindsets about our own personal health, despite going to very similar medical schools and training at the very same hospital for our internal medicine training, Mass General in Boston. So why are we telling you this? We're pointing it out to show that doctors, experts, have these medical mindsets and it can impact the advice that we give. But of course, when you're making decisions around treatment, you have to consider the evidence, the numbers, data from clinical trials. Shouldn't these numbers give you the information that you need to figure out what is best?
So one of the first patients we spoke with is a woman we will call Susan Powell. Susan is in her 40s, works as a nursing assistant, and on a routine checkup was found to have an elevated cholesterol level of 240, the normal cutoff 200. Susan's an active person. She walks regularly, follows a healthy diet, does not smoke, doesn't have hypertension or diabetes. And her doctor said, Susan, you need a statin medication. This will decrease your risk of a heart attack by 30%. That made an impression on Susan, but she did not immediately fill the prescription. While surfing the internet, she came upon what is called a risk calculator. And a risk calculator answers a key question that everyone should ask himself or herself, regardless of their condition. And that is, what is my risk of a certain outcome without any treatment? Now, in Susan's case, a woman in her 40s with a cholesterol level of 240 and no other risk factors, the chance that she would have a heart attack in the ensuing 10 years is 1 in 100, or 1%. Now, even if she were in her 50s and her cholesterol level had risen to 280, her risk of a heart attack over the next 10 years would be 2%, 2 in 100. So you see how your mind plays a trick on you. When you hear that a statin medication will reduce your risk of a heart attack by 30%, it sounds to you as though you are at 100% risk for a heart attack. But in Susan's case, it's really 30% of 1%. Or if she were in her 50s with a higher cholesterol of 280, it would be 30% of 2%, which clearly has a much different impact in terms of thinking than what she had originally heard. Now, we spoke with some patients, like a woman we will call Michelle Bird. Michelle is a maximalist and a believer. And she said to us, I could be that 1 in 100 who's going to have the heart attack over the next 10 years. I'm taking the statin. But Susan was a minimalist and a doubter and was not convinced by the numbers.
But there's more to Susan's story than just numbers. Shortly after she was given the statin prescription, she went to a dinner at her church. And there she met an acquaintance who was hobbling around, appearing very uncomfortable and unwell. And Susan spoke to her, and it turned out that the woman had been prescribed the very same statin medication that had been prescribed for Susan. And the woman had developed a side effect, the most common side effect caused by this type of medication, myopathy, muscle pain. Now, as you know, stories like this can have powerful effects on all of us. Cognitive scientists call the effect of stories availability because the dramatic story stays in your mind and is readily available. And these kinds of stories lead us to overestimate the likelihood or probability of the same thing happening to us. So although stories can sometimes be helpful, they can also be misleading, making something rare appear likely. So when you hear a story like this, you need to know the numbers. How common is this side effect of myopathy while taking a statin? So it turns out that the number ranges from 1% up to about as high as 10%, depending on the type of statin, the dose, other medications that the patient might be taking, or other medical problems. Now, 10%, that might sound like a pretty high number. But if we present or frame the information in the opposite way, between 90 and 99% of patients will not have this side effect. And this sounds better, although the information is just the same. So when you're helping a patient make a decision, or you're making a decision yourself, it's important to flip the frame, to view the information in both the positive and the negative. Now, you might think that framing is primarily a problem for patients, but in fact, a recent Swiss study showed that physicians are just as susceptible to framing as patients are. So how do patients and physicians get numbers and other information about the risks and benefits of medical treatments? Well, one way is through pharmaceutical advertisements, and these can easily be accessed on the internet. And it turns out that when patients hear numbers as they are presented in advertisements, they typically think, based on a study that was done at Dartmouth, that the medication is 10 times more effective than it really is. But this is not just a problem with advertising. It's an issue when you look at the results of clinical trials. So you've all seen the reports about the recent study on the Mediterranean diet that was published in the New England Journal not too long ago. And this is the abstract from that paper that I'm showing you. And the authors describe that patients who followed the Mediterranean diet had an adjusted hazard ratio of 0.7, which means a relative risk reduction of for cardiovascular events like heart attack and stroke of 30% by following the Mediterranean diet, an impressive number which was in every news report. So now let's look at the actual numbers from this study. So in the control group, 4.4% of the patients had a cardiovascular event, heart attack or stroke. In the Mediterranean diet plus extra virgin olive oil, 3.8% had a cardiovascular event. And in the diet plus nuts, 3.4%. So the absolute decrease in events was 0.6% in the diet and olive oil group and 1% in the diet plus nuts group. So I think you'll all agree, if I reconfigured this abstract to say that the absolute decrease in risk with the Mediterranean diet plus nuts was 1%, you'd be a lot less impressed than you were when you heard about a 30% decrease in risk. So you can play games with numbers, and we all need to be very careful when looking at relative rather than absolute numbers. But even more importantly, returning to Bernoulli equation that Jerry discussed at the beginning, making the best choice involves not only knowing the numbers, but how you value those numbers. So it turns out that there are many areas of medicine that fall into a gray zone, where there's not a clear right answer that is right for every person. And I'll give you an example from my own practice. As an endocrinologist, one of the most common things that I see are thyroid nodules. Now, most of these are benign, but some are malignant. And so to evaluate them, we typically do a needle biopsy. But sometimes the biopsies don't give a definitive diagnosis. Sometimes you can't even get enough cells, even on repeated biopsies. And then we need to make a decision. Is surgery required? So recently, I saw a patient who was in this situation. She had gone to each of the 3 Harvard teaching hospitals for this thyroid nodule, had 3 biopsies, and on none of the biopsies could we get enough cells. So what are the numbers? The risk of malignancy in this setting is somewhere between 2 and 12%. So she said to me, "What would you do?" Now, what would you do? That's a question we get asked all the time as doctors. So I said, well, looking at these numbers, if it was me, I'd watch and wait. But if it were my husband, Jerry, he would have had surgery yesterday. Different medical minds, looking at the same number. So we're not suggesting that the doctor and the patient have to have the same mindset. Sometimes being challenged can help you make a better decision. But doctors need to understand and respect the patient's mindset, and patients need to understand that doctors have a mindset too. Now, thyroid cancer has been in the news a lot recently. It's a lot like prostate cancer. It's very common. It's often indolent, sometimes very aggressive. And just like prostate cancer, death is often the only outcome that is measured or discussed. But like prostate cancer, death is not the only issue that should be considered in treatment. Paul Slovic, a leading researcher on risk, has pointed out that when experts judge risk, their responses correlate highly with technical estimates of annual fatalities, meaning death. However, risk means much more to most people than simply numbers of death. The conceptualization of risk is much richer than that of the experts and reflects legitimate concerns that are typically omitted from expert risk assessments.
So let's return to the controversies about cancer screening that Pam talked about earlier in the talk, mammograms and PSA. A review in the New England Journal of Medicine, looking at the recommendations and the data. 4 different expert committees came out with 4 different recommendations with respect to when a woman should begin to have mammograms, what age, and how often. The controversy of PSA screening, as this audience well knows, pivots on 2 randomized controlled trials published in the New England Journal of Medicine in 2009. The American trial had a PSA screen group and a control group. You would imagine that the control group would not have had PSA screening. But in the American study, the controls received, quote, usual care. More than half of the men in the control group actually had undergone PSA testing. The American study showed no benefit in terms of mortality with PSA screening compared to the control group. But also, as you know, a large multi-center European trial did show a benefit, although from center to center, there were not uniform criteria with regard to how often to screen and what cutoff should be used for biopsy. Now, 3 different expert committees. The United States Preventative Services Task Force, which is convened by the United States government, the American Society of Clinical Oncology, of which I'm a member as an oncologist, and the American Urological Association, each came up with a different opinion based on these same studies. The government panel made what's called a grade D recommendation. That is, they recommend against screening for healthy men. In fact, they state it should not even be brought up with the patient. The American Society of Clinical Oncology recommended considering screening for men with a life expectancy greater than 10 years, with the individual decision being made between the physician and the patient. And the American Urological Association made a grade B recommendation. That is, recommended screening, but primarily for men between the ages of 55 and 69, with, again, the individual decision made between patient and doctor. So you have 3 different expert committees with 3 different opinions.
So why do these expert committees disagree? We believe that they disagree because they reflect different mindsets. With regard to both mammograms and PSA screening, the United States Preventative Services Task Force represents the minimalist doubter point of view. Less is more. And this has become an increasingly popular point of view given the rising cost of health care. Other professional societies represent a maximalist believer point of view. But none of these recommendations are strictly objective. Everyone is looking at the same data, but they value the information differently due to different mindsets.
So how can you, as the doctor, with your patient, make a decision that incorporates these aspects of life rather than just considering mortality? We think it's essential to assess 3 dimensions. The first is your patient's mindset or medical mind. Is he or she a believer or doubter, a maximalist or a minimalist, has a technology or a naturalism orientation? But that's just the starting point. Then you look at the numbers and you try as best as you can to understand how the numbers apply to that individual. Now, finally, in terms of stories, in terms of evidence-based medicine and scientific thinking, we often dismiss stories as mere anecdotes. But it turns out that research done by the cognitive scientist Daniel Gilbert at Harvard, published in the journal Science, in terms of how to better estimate the impact of a certain outcome on your life, That second part of the Bernoulli equation, the utility, is best done by talking to someone, interacting with someone who has had that outcome, particularly someone who is similar in background to you. So you try to get your arms around his or her experience with a certain condition. And in fact, we learned from our field research, speaking to many men who were given the diagnosis of prostate cancer, how they came to their decision, struggling among the choices of surgery, radiation, or active surveillance, watchful waiting, that talking to other men who had chosen different paths was enormously helpful for them to arrive at a decision with their physician. Now, of course, you have to be careful about anecdotes, the N of one. But on the other hand, they can be extremely valuable to patients to give them a concrete, palpable sense of what life may be like with a certain medical condition. Basing decisions strictly on the outcome of death ignores vital dimensions of life that are not easily quantified. There are real complexities, real uncertainties that we all, physicians and patients alike, confront when we weigh risk and benefit. Wrestling with these uncertainties requires nuanced and individualized judgment. It is neither ignorant nor irrational to question the wisdom of expert recommendations that are sweeping and generic. There is more to life than death.
Thank you.
Thank you.